Okay, so welcome everybody to the next in our series of podcasts, which is run by ECIST. My name is Stephan, Natawidjaja, and I'm an improvement manager. And today we are going to be talking about the topic of RAT. And we're very privileged to have Rob Pinate here with us, a consultant nurse at University College London Hospitals. Welcome, Rob.
Thanks very much, Stephan, and thanks to everyone who's joining us on this cast. So I'm a consultant nurse at UCLH, as Stephan has said, and also a clinical associate with ECIST. So you're all very welcome.
Thank you very much for taking the time to chat to us. So I guess for us really, what would be really helpful is if you could explain to us kind of what is the purpose of ratting really? What does it mean for us simple folk?
Yeah, so it's been around for quite a while now. So rapid assessment and treatment, RAT, which is an unfortunate an acronym, unfortunately, because a lot of people don't like it and change it. But it does what it says on the tin. It's supposed to be a rapid assessment and initiation of treatment for patients coming into your emergency department. Often, most times, what you will find is that the RAT system, the RAT team, is targeted at the ambulance flow incoming into your department. Obviously not resus blue calls, but the ambulance flow. And we can talk a little bit later, actually, you can expand that out and actually have it as a broader assessment team. But initially, that's what most people would target, is that ambulance arrival, the offload of ambulance patients into your department, and that initiation of treatment by a senior clinician. So that the key thing around rapid assessment and treatment is that it's senior clinician led. And
you mentioned the team there. Who would you recommend there being in the team? Yeah, so it's a good question. I think the key thing here is that it's a team. There is actually some published papers, because I've looked at this extensively over the years in developing RAT systems in other organisations, not just at UCLH. And you will see papers that have been published around individuals effectively taking a consultant or a senior registrar and putting them at the front door of your emergency department on their own, or with a triage nurse or a streamer. That's not really what we're talking about. What we're talking about is having a team approach. So normally you'd have at least a decision maker. I would advocate potentially more, depending on the size of your department and your flow, but also nurses and healthcare assistants or support staff. Some people have technicians in the department. Some people have physicians associates in their department. It doesn't matter, so long as that there is an adequate team in terms of thinking about your capacity within that team to meet the demand. And I think the key thing here is that there's no menu or recipe for this. We can give you some guidance, but actually you've got to develop it to fit your department. And actually the best models that we've seen are the ones that the department themselves have obviously developed for themselves, and it meets their needs. Yeah, because obviously being a national team, we come across a lot of different emergency departments. And there's always a debate in terms of RAT. And I guess that debate kind of surrounds it. Should there be an identified area for RAT, or should it be considered a process? What are your thoughts on that?
Yeah, it's always a challenging one. I think the key message that I would get across is that it's more about a mindset change rather than a physical space. The idea that you can just build a space and then suddenly you will have rapid assessment and treatment and it will work, it is not the case. My own experience is we've actually created a RAT area, and initially it didn't work. It does now, which is great, but actually not initially, because it's the mindset that you need. I think a slightly different way to look at it, so you're going to think I'm contradicting myself, but I'm not, I promise, is that there is advantage in having a dedicated space or area for that purpose of rapid assessment and treatment. So if you think about the ambulances arriving in your department, it is clearly advantageous to have an area set aside where those ambulances will arrive, where the team can coalesce, where they can offload the patients, work them up, and then move them on. However, that doesn't mean you have to build more space. It could be that in your existing footprint, i.e. majors, most people would look at, actually, if you took out 4 cubicles for RAT, you might think, oh, well, I haven't got enough cubicles now for majors. But that then misses the point about rapid assessment and treatment and what actually can happen with your flow, which we might get into later.
Okay, because I think a lot of people will be alarmed if you're talking about moving majors cubicles.
Yeah.
So yeah. Can you explain your thoughts behind that then?
Okay, so you're absolutely right. So a lot of people get very nervous about saying, well, why don't we just take 4 cubicles out and give them to the rat team, and then you've got 4 fewer cubicles for your majors group. So let's say, for argument's sake, you've got a 16 bedded majors and you take 4 out for rat. That only leaves you with 12. So immediately you'll think, well, 12 isn't enough. I mean, 16 is not enough. So how is 12 going to be enough? So if your rat system is working well, what should happen is that fewer patients actually go through to your majors area. So what do I mean by this? RAT should be making decisions such as referral to inpatient teams and making those decisions to move those patients. So it might be that the RAT team says, actually, hang on a minute, you can go to our UTC, so that patient never hits majors. You can be referred from RAT to a speciality. Depending on your model in your hospital, you may have an assessment area for medicine. You may have an SDEC, a fully fledged SDEC. We have a multidisciplinary SDEC, multi-speciality. So we can refer from RAT to a speciality, and they will go from RAT to SDEC. They don't even hit majors. And actually what we've found is that approximately a third of the daily speciality take or referrals from ED come from RAT. If you can move those patients from RAT to another area other than within the emergency department, you've just reduced the number of patients going through to your majors area. So you have fewer patients going through to your majors area, therefore actually you can have a model whereby you're effectively giving up space in majors.
So I guess that sounds like it has a really positive impact on crowding within the emergency departments then, because we're getting the patients in the right place earlier on in their journey.
Yeah, yes, it can do. And of course, the challenge for all of us is, what do you do when those spaces become full and it backs up into your department? And some hospitals, many hospitals, don't have mature systems yet in terms of SDEC and places to send people. But obviously, that's what we're all trying to work towards. And it can be a real challenge. So I've worked in my own department and also in previous departments that I've worked in where we've done RAT, where we've made the referral, but actually there's nowhere for the patient to go. It continues to be a challenge, but I think it's about establishing the principles behind the rapid assessment and treatment process and actually what the outcomes can look like. It may also then pose questions for your organization about, well, hang on a minute, the RAT system is actually working well, but these patients have nowhere to go. So that then highlights where the challenge actually lies, rather than it being hidden in there's long waits to be seen by a doctor in A&E, because hopefully this will alleviate or answer some of that challenge.
And I also think one of the interesting points you made is earlier on you spoke about the team, so the ratting team, if you like, and it sounded very much like it was an internal team within the ED. But then further on now in our conversation, we're drawing in now speciality teams as well into that process, so they almost form part of the peripheral team. How's kind of that been and worked for you?
Yeah, so I think this is one of the sort of key areas that I would suggest that departments or organizations think about in advance or whilst they're doing it. You really need to have your speciality teams on side. And what I mean by that is that they understand the RAT process and they understand what the outcomes from RATs may be. Now, if you've got a senior clinician in there, they're going to be getting referrals from that senior clinician. So, you can be assured that it's a senior clinician decision. But in the absence of all the sorts of stuff that we may have historically asked for, like a full suite of blood results, imaging results. So when I work in RAT, I'm referring patients to specialities, to surgeons, to medics, to gynae, to orthopedics, in the absence of a lot of results. And actually what we're doing is we're basing a lot of our decision making based on the history taken and a good clinical examination. So it's good standard emergency medicine, if you like, and nursing practice, where it's identifying those patients that early on. So you need to have your specialty teams on side, that they understand that actually they're going to receive referral requests from senior clinicians in the absence of a full suite of results.
And was that a difficult mind shift?
Yeah, I've done it so many times because I've done it in 3 different departments over the years. Yes and no. I think there are some specialities that may provide more resistance to it in the early phases. But I think, so one thing I did, this was years ago in a previous department, is we actually looked at what was the deemed by the specialty teams to be a good referral, i.e. it was an appropriate referral to them, and not one that they felt that actually shouldn't have been referred or should have been referred to a different team, from a sort of rapid assessment and treatment initial workup. And actually we found we were somewhere in the 90%, being reported back to us as, yes, this is a good referral. I mean, we can argue for hours about what is a good referral. And I think the team started to see that actually we weren't just chucking everything at them because we wanted these patients not to be in our department or not to be our responsibility. Far from it. Actually, what we were finding is that we were able to have that early decision and differentiation of patients to those specialities. And of course, in any ED, actually, a lot of patients we won't refer, we will manage, and we will discharge from the emergency department in totality.
So I guess the big question is, how do you know then whether the process is successful or not? How would you measure the ratting process in terms of a successful improvement process or program?
Yeah, so I'd be the first to admit a lot of it is time driven, by virtue of the fact that we're measured on time in so many ways, not just the 4-hour standard. So I think that the two key ones that pretty much everyone looks at is look at your ambulance handover performance. If the rapid assessment and treatment team have that responsibility to receive those ambulances, then of course you want to see that those ambulance handover times are good. So you will already have that baseline data, so you can see if it's made a difference or not. And trust me, when we first launched the latest incarnation of rapid assessment and treatment at UCLH, our handover times were poorer initially, so just bear that in mind. But now they've become much better, so that there is an element of allowing the model to mature in your own department. So ambulance handover, and the other one is time to treatment, and you can include time to assessment as well in that. So a lot of departments we will obviously measure both, so you can look at those. The other things that I would suggest that departments look at, and something that we look at and I've looked at previously, is time to referral to specialty teams where required. And I've seen significant reductions in time to referral, which then buys or gives your specialty teams more time to then do what they need to do with the patient. And again, you're talking about the mindset change and how do you enroll your specialty teams? Well, that's one hook, I guess, giving them more time to actually do what they need to do. Then there's other time-based, but I think it's more about the quality of care that we give. So time to analgesia, time to first-line antibiotics, particularly in sepsis, time to investigations such as ECGs, imaging, and bloods, all of which hopefully you will see a reduction in, and ergo is an improvement in the quality of care, particularly when you're thinking about pain management and sepsis management antibiotics. A lot of people focus on one last one, which is length of stay within your emergency department. I would just flag a note of caution. There are so many factors which impact on total length of stay within your emergency department. Just be careful that you don't put all your eggs in one basket and say, well, we're going to rat, so we're going to see the breaches go down. The first thing to do is to segregate out your patients going home from your department and see if rat makes a difference to those, because that is within your gift to a degree. And then see your patients being referred to specialty teams and being admitted and see if you see a reduction. Now, we have seen reductions in both of those groups. I've seen reductions, and we've actually measured that at my previous trust at King's, and we saw a statistically significant reduction in both of those. But the international literature is mixed. In fact, some saw a rise, some saw a fall, and some saw no change at all. So just be careful that we don't. I think I worry when I hear people say that rat will sort out my breach problem. It won't. There's so many other factors. Can it be part of a suite of improvement which will help in terms of patient flow and management? Then yes, of course it can.
And kind of you mentioned it there earlier on about patients. I'm quite intrigued to know kind of what's patients' feedback around undergoing a different process. You know, how do they feel about it? Do they experience benefits? Are they satisfied with the service that's being provided?
Yeah, I mean, and to my own, I'll be the first to admit that I've not formally measured this, other than obviously the anecdotal patient feedback you get at the time, but also patient feedback we get from like the friends and family feedback that we get. But overall, certainly my experience, it's overwhelmingly positive. The patient feels that they're being seen by a senior clinician very early on in the process. Historically, we have models of actually when you go to majors, you get seen, you get assessed by a nurse, they work you up, you then get seen by a junior doctor, they work you up, and then then there's a wait for results, and then finally you get the senior doctor in almost at the end of the pathway, and RAT just flips that. It literally just flips it around and says, well, if the senior clinician is required in terms of input into this patient, why don't you put them at the beginning of the patient journey? So we've found that there is a lot of positive feedback from patients, and also I think it's really important that the nurse, the doctors, the HCAs, whoever it is in your RAT team, when they go and see the patient and they start that initial workup, is that they explain to them what their role is. So when I go and see a patient, I say to them, look, this is the rapid assessment area. I don't say this is the RAT area because that really confuses patients. This is the rapid assessment area. My job is to try and get everything going. I might not be able to complete your care, but at least I can get you going in the right direction and explain to them what's going to happen next. I think that's a really key thing. I'm going to move you on into majors, or actually, by the way, I'm going to refer you and you're going to go to our SDEC. But yeah, overwhelmingly positive in my own personal experience.
So I guess that's the beauty of it, isn't it? We're starting involving the patient in their journey there and explaining to them exactly what's going to be happening to them and what the next steps are, which is really good. I've heard that also that you're doing something quite interesting in your department as well, in terms of, we've spoken a lot about the back end, i.e. the ambulance arrivals, but you've also incorporated it into the front end, i.e. those that are walking through or ambulatory side as well.
Yeah, so I've developed rapid assessment and treatment systems in now 3 organisations, and UCLH being the latest one, which actually already had a RAT system in place, but we've just developed it and grown it since I've joined them. So as I said at the beginning, most people focus on ambulances, and I've always held a belief, I guess, that if a patient requires majors level care, why is it that mode of arrival should differentiate you into different care groups, as it were? Some receive RAT and some don't receive RAT. So at UCLH, what we did is, once we kind of got a solid ambulance arrival RAT system, is then we went sort of big and we said, right, we're going to actually put all patients that require majors level care through RAT. So that's all the ambulance arrivals that don't go immediately into resus, and all the patients streamed to majors from the streamers. So going back to the question about resource as well, we were like, oh, how am I going to get enough nurses, HCAs and doctors to be able to meet that demand? I'm taking all the patients now. So at the time when we launched, it was about 110 patients a day, of which about 50 to 60 were ambulance borne. The rest were walk-ins. So that's the majors population. And it was like, oh, how are we going to meet that demand? And actually what we did, and we were quite brave, I think, in retrospect, is we had a system where we had streaming nurses, and if the streaming nurse think, you need to go to majors, they would then pass that patient over to the triage nurse, who would then do more detail. And then also you would get diagnostics from an HCA. This was all out the front in sort of triage cubicles. So we took the leap of faith, and we actually stopped that. We stopped triage and diagnostics, and we moved that nursing and HCA resource and said, you're now part of the RAT team. So the streamers still say, I think you need majors, but instead of sending them through to triage for further assessment, they send them to RAT. And the resources moved with that. It's challenging, but actually now all patients that go through to majors have gone through rapid assessment and treatment, and that fundamentally changes your majors model as well.
And you just brought up a fantastic word, which I'm quite intrigued about, and is that word challenge. So I guess for me and our viewers and listeners, is what were your challenges and how did you manage to overcome them?
Yeah, so I've actually already dealt with the first one, which is team. I think for any organization, just think about and give some thought, a lot of thought about your team. You know how many ambulances a day you get. So let's just say we're starting with that. So just have a think about how many people you think you're going to need to be able to meet that demand. And we know ambulances don't come nicely separated out in time slots. They do come in batches or blocks. They do come in groups. They're like buses. So we need to model against that. So we just looked at our total ambulances per day. We knew the fluctuations, and we said, look, if each RAT episode takes approximately 30 minutes, and that's what we aim for, so a median time of 30 minutes, some will take a bit longer, some will be shorter. How many spaces do we need? And we came up with a magic number of 6. So that was for us. That might be different for you. So just bear that in mind. So think about your team, your resource, and what sort of space you might require to be able to provide that, which is kind of 2 things in one, team and space. Now it's a mindset. It's not just about space, but we've had that discussion already. The other challenge is what I call the wider system, and actually we've already talked about that. So that's engaging with all of the other specialities and other areas. So RAT would not work unless we worked really, really closely with our SDEC colleagues in my organisation. It has to work together. So SDEC is set up and understands that they are going to get patients directly from RAT. That the RAT team will call them and say, have you got a space? I'm going to send this patient over to you. They've been accepted, etc. And then the final one challenge is, again, we've covered it already, but just to re-emphasize, be careful about saying that RAT is going to solve my target's problem. It won't necessarily do that. And I think we need to not lose sight of, whilst the patient journey may improve, hopefully will improve, the quality of care that we deliver should improve. So even if your patients can't move on because of lots of other factors within your organisation around flow and capacity beyond the emergency department, at least we are making decisions earlier. At least we are instigating treatment earlier. At least we're dealing with their pain earlier. And surely that must also be why we should be doing rapid assessment and treatment, not just trying to meet a target.
Okay, well, thank you very much for that, Rob. I think that was really insightful. And I guess, some of the things that I've taken about that is that it's not something that can be just implemented tomorrow. It needs a bit of thought process given behind it. And I absolutely love the fact that the experience for the patient and the quality of the care of the patient seems to be at the key of what's driving this, rather than looking at the numbers in terms of whether that's time or whether that's the quantity of patients that you're getting through. So, fantastic that it's really patient focused, and that's what's driving this. And I love the way that you've thought about it differently and evolved the process to include the front end. So I think that's really innovative. I always struggle with that word. So thank you very much for that, Rob. It's been an absolute pleasure talking to you. I think that will be really helpful to people. So thank you.
Thanks very much, Stephan. Thanks, everyone.